Well, hello everyone. Good afternoon and welcome to our Q&A session with Dr. Jennifer DeSimmone, who joins us from Virginia and the Inova health system as a specialty dermatologist and specialist in cutaneous lymphoma. And we are also joined by Dr. Alison Moskowitz, who comes to us from Memorial Sloan Kettering in New York as a hematologist specializing in T-cell lymphomas and doing a lot of research in the area of T-cell lymphomas. So thank you both for joining us on this Saturday in September. And I know it's a busy time of the year for everyone, especially for those that have children going back to school and events and activities. So we really appreciate you all taking the time to be with us for the next hour and to answer some questions. I will say for everyone in the audience, if you can do your best to try to ask the question in a way that is not necessarily specific to your diagnosis. The physicians obviously cannot answer very specific questions related to your care, and we would suggest that you ask those questions of your own physicians. But we will address as many questions as we can in the next hour, and you can put them in the chat, and I will be able to see them on my other screen. And if I did all my technology right, which I hope that I did, and we can go ahead and get started. So thank you again both for joining us today.
Happy to be here.
Thanks for having us.
Yeah. So I will we'll start off by what I hope is an easy question, or maybe not so easy question. But since we both have dermatology and hematology oncology here with us, we always get a lot of questions with regards to who should really be managing my care if I have a diagnosis of cutaneous lymphoma. When should I see an oncologist versus a dermatologist? How do I kind of navigate my healthcare providers? And maybe we could kick off with a little bit of that, both from your different perspectives. Maybe Jennifer, start with the kind of your view coming at it from the dermatology side, and then we'll flip over to Dr. Moskowitz for the hematology side.
Sure. So I think the question of what disciplines you need involved in your care really depends primarily on your burden of disease or your stage, and the duration of your disease and the pace of your disease. So for someone who has less than 10% of their body surface area involved with patches or thin plaques, stage 1A patient who, and as is commonly the case, had some sort of rash going on that was not correctly diagnosed for some years before they ultimately discovered that they did in fact have cutaneous T-cell lymphoma. Those individuals have an excellent prognosis and are largely fully manageable by a dermatologist. And you can get some disagreement about what needs to be done or what's indicated in the initial workup of a patient like that. But in most cases, things like a PET CT or specialized flow cytometry are not indicated for those very limited, rather stable stage 1A patients. So that patient could be managed by a confident dermatologist, even in the community, who has some skill and some experience with this rare diagnosis. That said, and I'll transition over to Alison, I think increasingly, particularly in more urban centers, we're trying to focus on assembling multidisciplinary teams that include all of the disciplines that anybody across any stage might need. I'm sure, Alison, that's the case at Sloan Kettering. That's certainly the case with us. So we, as new patients request a consult or a new patient appointment, I review each packet and determine before they even get scheduled who they might need. And so that's the ideal scenario, is where you're able to be seen at a multidisciplinary center where they have a CTCL program.
Yeah, I completely agree with that. And because we do get to, I am lucky enough to work in a multidisciplinary clinic at Sloan, and as a result, I end up, even as an oncologist, I end up seeing the full gamut of stages, and often an individual with early stage disease, as you described, having less than 10% of their skin, and and having just, minimal patches or plaques. Sometimes I will see them initially with the dermatologist, but potentially either never again, and have it and have the dermatologist take care of them going forward, or see them once a year. I think because we're in, because of the center where we are, sometimes it's a little, it's reassuring to the patients that, to hear from both of us that this is something that is associated with a good prognosis, and, and this, can very well be managed with skin directed therapy. And then also it's nice that, maybe we've met, in the beginning that, if the lymphoma ends up becoming more extensive and more treatments are needed, we already have a connection and, and are there for them, when, if our dermatologist colleagues feels like they need to have us weigh in sooner.
Great. So this is an interesting question and probably in the realm for Dr. DeSimmone. So what do you recommend for an MF patient who also has eczema in addition to cutaneous lymphoma or MF, and the eczema is worsened by phototherapy, but it helps the MF? Any ideas? And I'm sure there are other folks out there that may have multiple skin conditions, right, in addition to the cutaneous lymphoma. And I'm just going to make the assumption that they've been properly diagnosed with MF, and MF and eczema combined, which is probably challenging in and of itself.
So that's a semi-unique scenario because eczema tends to be involving one domain of immune errors in the skin that is kind of the opposite pole of how MF pathophysiologically evolves. So it's unusual for someone to have true bona fide moderate to severe atopic dermatitis and then also have true bona fide biopsy-proven mycosis fungoides, just because they have a little bit of a different pathophysiology, and it would be unusual to have those competing pathophysiologies present in the same patient. That said, I've definitely seen this at least a dozen or so times. And it's interesting because things like topical steroids and phototherapy are both indicated in both diseases. So you can get a lot of overlap in how you treat the patients. I understand the challenge that is referenced here, which is patients having a hard time tolerating light therapy. And so I think that if your provider has determined that phototherapy is the best treatment for you, there are ways to customize or individualize phototherapy to help people who are not tolerating it with the usual standard protocol be able to better tolerate it. So things like decreasing the number of times per week you initially are getting your sessions, having a very slow upward titration of your overall time in the light box, using steroids immediately after you have your light session. Things like that, those little tweaks can really help to make the phototherapy more tolerable and therefore address both issues. That said, there are other things, if your physician wants to get a little more creative, that also can potentially kill two birds with one stone. Things like topical JAK inhibitors, creams that are anti-inflammatory at a specific point in the pathway that may be helpful in both disease processes. That's something to consider as well. But again, you really have to dig in with your provider to make sure that you really do have atopic dermatitis and that you didn't just have biopsies that were consistent with that prior to your disease evolving to the point where the biopsy correctly identified that it was in fact mycosis fungoides the whole time.
Yeah, that's always the challenge, right? Is that MF is so good at mimicking everything, particularly in the early stages and before it kind of defines or declares itself, even in a biopsy, even with the best dermatopathologist looking at a particular biopsy sample could still come back inconclusive. So yeah, very challenging. So here we go. A newly diagnosed MF patient, 1A, man, and has symptoms of skin feeling warm, facial flushing, clamminess. And is that consistent with MF?
I'm happy to let you
Either or.
Well, typically I think of, stage 1A means, that the skin lesions are really quite limited. So I actually would not think of the facial flushing and these symptoms as typical of having stage 1A. And, it would make me want to look into other causes for the facial flushing, or to look to see if maybe the flushing is really, erythema, that's, just redness that's related to, maybe a more advanced disease. I'd be looking at blood work to see if there's any hint that the lymphoma's in the blood, and also and maybe just other causes for the facial flushing. So that's not something that I would think of as typical of stage 1A.
Right. Jennifer, anything else?
No, I
from
agree.
your side?
I agree entirely. By definition, stage 1A means that you have disease that's isolated to the skin. So you should not be having any sort of vascular instability associated with that, which would be a systemic complaint.
Okay, thank you. Gosh, questions are coming in fast and furious now. Everybody has woken up. What are the frequently experienced side effects of low-dose bexarotene, oral bexarotene, and how long can it be used if found to be effective? Good question.
Yeah, that's a great question. So that's, one of my go-to drugs. So, I'm using it quite often. As far as low dose, typically the doses that I'm using is typically 4 pills a day, so 300 milligrams a day. I don't know what the question, what dose they're referring to, but even at a lower dose, the main side effects are it affects your thyroid as well as your lipids. And so those are the main things that we look at. It basically turns off your thyroid in almost everybody, and causes your triglycerides to rise, which is one of the markers that we look at on a lipid panel. And so we routinely will, that it's part of our standard that, when we start bexarotene, 2 weeks later, I usually start it with a medicine that will help keep the triglycerides under control. I usually start it with fenofibrate, which helps with that, unless the individual is already on cholesterol lowering medicine. And then I usually check labs 2 weeks later. And at that time, we're usually already seeing effects on the thyroid. And then, and we often have to start Synthroid for that. But it takes some, and occasionally there is an individual who has a really high spike in their triglycerides, and it's an indicator that we probably are not going to be able to continue the bexarotene for that individual. But most people, we are able to find some balance with the bexarotene, anti-cholesterol medicines, and the Synthroid, and we find the right doses and the right combination. And then if the bexarotene is effective for the lymphoma, which in many cases it is, and it does take some time for it to work. Sometimes we get lucky and we see responses early on, but usually we say that it can take about 4 months before we really see efficacy. But the nice thing about what I love about bexarotene is that once you find that balance, and if it's working, you really can continue it indefinitely, and it can be a nice chronic medicine to keep things under control. Sometimes we'll add light therapy to it, and that can really enhance the efficacy if we need it. But even alone, sometimes that can be a nice long-term medicine. And so there's really no end that you have to, there's no reason to have to stop it. And I'm really, if it's working, I would be very hesitant to stop it, because my expectation is that the lymphoma would start coming back.
Yeah. Dr. DeSimmone, anything to add? Maybe any conversation on diet recommendations, because it does change the impact on cholesterol levels. And I know some folks, also look at adding and modifying their diet when they are on bexarotene, oral bexarotene.
So I agree with everything Dr. Moskowitz said. The main side effects that you feel are usually while we're still trying to get the thyroid into goal range. Most people otherwise tolerate it quite well. So the side effects are usually lab-based issues. The triglycerides do go up. And so you, of course, want to try to avoid additional sources of high fats in your diets. You want to avoid fried foods, a lot of butter, things like that. But for the people who are just genetically predisposed to having a big reaction in their triglycerides from this drug, the effect or the impact of diet on being able to mediate that is pretty small. But of course, trying to give your body the best food you can and keep everything on an anti-inflammatory type diet with low fats, avoiding animal fats and processed foods is always going to help your immune system in general to function maximally, which in turn helps you control any sort of disease your body's facing.
That's great. Thank you for that. Good diet, exercise, right? A baseline for everybody, physicians included, right?
Yes,
For
for
all
sure.
of us. Well, that actually brings up another good question with regards to labs and testing, and maybe we can talk a little bit about when someone is newly diagnosed, what is the general panel of testing that is required, and perhaps a little bit about which tests get done, maybe for what different variations of cutaneous lymphoma, and then, over the course of time, what should patients expect for monitoring? What should you be thinking about with regards to, we all do our annual checkups and screenings and so forth. So are there things that patients should anticipate going forward to monitor their disease, and how does that happen?
I'm happy to start with the
Okay.
initial step, and then I can pass it on. So anyone who's stage 1B or higher definitely should have a flow cytometry done and a CBC at bare minimum. And what you're looking at there is you're looking for the presence of any of these cells that we know cause problems in the skin, CD4 positive T lymphocytes usually, in your average straightforward mycosis fungoides case, and you're trying to tabulate the number of cells in the circulation that also fit that abnormal profile, because you want to check if you've got disease in the skin alone or if you've got disease in the skin and potentially in the circulating blood as well. And then every patient should have a thorough lymphatic exam to include evaluation of what we call the skin draining lymph nodes. Those are around the neck and the underarms and the groin area. Those lymph nodes are readily accessible on exam and are really important to be evaluated at the beginning. And then I do it at every visit as well. If you palpate anything that is abnormal, an enlarged node, then you can talk about what imaging might be indicated, meaning CT scan or PET CT scan, and then we go from there. And then I'll let Dr. Moskowitz take it.
Yeah, I completely agree with that. It's we try to do a minimal, we try to do a little less for when the disease is minimal, for example, the stage 1A, because sometimes doing too many tests can end up finding some false positives and that are not necessary to follow up. But I completely agree that for someone who has stage 1B, which as we had mentioned has more than 10% of their skin, then we really also want to look to see if there's blood involvement, and then for if there's that. I agree, that if we palpate any lymph nodes on exam, we're certainly going to want to follow that up with imaging, such as a PET scan. I typically will do a PET scan at baseline for people who have stage 1B, particularly if they have what we call follicular tropic disease, which means that the plaques or the lesions are kind of a little deeper into the skin and involving the hair follicles, and sometimes those can look like nodules or even areas of hair loss, and so those sometimes that can be a marker that we might find more extensive lymph and disease. So we'd like to get a baseline to see where we're starting. As far as what if we find something on the PET scan? Let's say we find enlarged lymph nodes that are showing some activity. it doesn't, I don't always refer people for a biopsy. I mean, technically the staging for cutaneous T-cell lymphoma, it includes knowledge of whether or not the lymph nodes are involved. But if it's an individual where I'm going to be starting systemic therapy and the lymph nodes are, fairly on the smaller side, I assume that maybe they're minimally involved by the lymphoma, and I also assume that the systemic therapy I'm going to start, such as bexarotene, would help those as well. If there's a lymph node that really looks different, that looks kind of large, really bright on the PET scan, then it would be reasonable to do a biopsy, because one of the things we want to look for is not only whether or not it's involved by the lymphoma, but whether or not it really is, representing a more aggressive form of this, which we call large cell transformation. And so, depending upon what we find in the PET scan, we might want to follow that up. Sometimes, occasionally, this type of lymphoma can go to an organ such as the liver or the lung. And if we see something like that, we'd want to biopsy it because it's unusual. So we'd want to kind of clarify what that is and see if it's involved or see if it's even, related to something different.
Right.
There was a question, I guess, about following, after we've determined the baseline and what do we do going forward. The way I look at it is that I see the skin as kind of our, gives us information about what's going on throughout the body. So I don't tend to do routine PET scans or CAT scans going forward when I'm treating someone or monitoring them, unless there's a real change in what's happening on their skin. And that I think is a signal that we need to look further and make sure that we're not missing something on the inside as well. Even with regard to blood work, I certainly want to determine whether or not they have involvement of their blood, which, and we do that with by doing flow cytometry. And we can, even for someone who has Sézary syndrome, we can monitor their, get a good idea of the level of Sézary cells in their blood, even just by doing a routine CBC. So I do the flow cytometry. I do repeat it, at some interval, maybe every 3 months or so, but I'm usually seeing those individuals even more frequently and able to get an idea of what's happening, just by watching their routine CBCs, their complete blood counts.
Great.
May I add one thing?
Please.
I think it's important. I try to reassure my patients because this question comes up a lot. And I think that it is emanating from a fear that there's going to be some tumor that emerges internally that we're not aware of, and then we lose the opportunity to treat them and improve the prognosis. So I routinely counsel patients, just exactly as Dr. Moskowitz said, that the skin is going to be a surrogate marker for overall disease activity. It's not like, say, melanoma, where the skin has already been treated and the skin looks pretty good, and then you've silently got something more sinister developing internally. The skin is almost always going to be a pretty reliable window to what's going on internally. And so I find that that's helpful to patients, to just let them know that it's a very different paradigm as compared to other forms of skin cancer.
Good point. I think that's a good point. I think that's one of the challenges with getting diagnosed with this disease, is that it tends to fall outside of the parameters of everything anybody might know about any other kind of cancer that you've heard about or had an experience about. Our staging is different. The way we treat is different. It's long-term, not short-term. Testing is different. Follow-up is different. And it's hard to wrap your head around all of that, especially when you're newly diagnosed, to go, well, how come you're not taking out the big guns and like eradicating this disease from my body? So thank you for that clarification, and appreciate maybe alleviating some people's anxieties over the disease. So this is a very good question, and we'll see who wants to take this. Is the idea of phototherapy that it slows the growth of MF, and what happens when you stop treating with phototherapy, and where does phototherapy play in the mix of the treatment options and regimens? So, because it's kind of a mainstay, right, for early stage disease.
I'm happy to take that.
Okay.
So I wish that phototherapy was causing direct destruction of the atypical T cells in the skin, but that does not appear to be the case. What phototherapy does is it helps to reduce or blunt the pro-inflammatory kind of secondary reaction, the inflammatory cytokine cascade, we call it, that makes the symptoms and the appearance of the rashes worse. So you've got these atypical T lymphocytes that are then kind of elaborating their own pro-growth, pro-inflammatory signals, and that makes everything even more inflamed, looks worse, feels worse. The light therapy is acting on that secondary component. And I think the feeling is that if you can really reduce some of those pro-inflammatory signals, then you can, in theory, reduce a lot of the activity of the abnormal T lymphocytes that are causing the problem. And so you can put people into a clinical remission in terms of how the skin looks and feels. But there have been many studies that have shown that even in the patients who look clear, if you biopsy that skin, you can still capture some of those atypical cells. So it's not a cure, but it definitely seems to kind of cut them off at the knees, so to speak. It takes these T lymphocytes and it reduces their ability to continue to elaborate their own pro-inflammatory signals.
Mm-hmm. And then, so what happens if you get to the point where your skin is clear? I know this is always a question, right? Do you go on a maintenance therapy? Do you stop? Do you take a holiday from light therapy? How do you figure that out and grapple with that?
So there are Sure. There are different guidelines and different approaches based on what type of light treatment you're getting. So if you're getting UVA-based therapy, we know that in the long term, there is an increased possibility for some carcinogenesis with squamous cell carcinoma, usually on a 15 to 30-year delay. But we do need to keep an eye on cumulative sessions with UVA. Also, it depends on the patient's degree of genetically determined protection against UV damage. So people who are very fair phototypes, very fair-skinned people, they have basically no protection against ultraviolet damage. So we want to be careful in looking at the total number of sessions that they get of any type of phototherapy versus patients who have a little bit more pigment in their skin that shields them from some of that ultraviolet carcinogenic damage for other skin cancers. So those patients tend to tolerate phototherapy in the long run a bit better. But it's what we usually do is adhere to the guidelines, whether you've got UVA or narrowband UVB as your phototherapy type, and you want to treat them ideally 3 times a week until they're completely clear. Then you hold for 4 to 6 weeks. Then you reduce down to twice weekly for another 4 to 6 weeks, watching carefully for any breakthrough disease. Then you go down to once a week for 4 to 6 weeks, and then you attempt to stop. And then you have to just follow the patient. And just like everything else with this disease, it's highly individualized, the course that patients are going to take. Some I've seen are then in remission for 10 years. Others are good for 6 to 8 weeks, and then things start immediately breaking through. And so once a patient has shown how well their skin is going to maintain a positive phototherapy response after the conclusion of phototherapy, you're able to get an idea of who needs maintenance therapy and who doesn't. A lot of patients also live in geographic areas where they can seek some natural sunlight during 1/4 or half of the year. And so oftentimes I'll give them a break from formal phototherapy and they'll supplement with some outdoor sunlight during spring and summer. And then in the winter, when they flare again, we can resume a course of phototherapy. So I guess the take-home message is you got to watch out for any damage that you might be doing with unlimited phototherapy. And you need to assess the patient and their individual risk for ultraviolet damage. And then you customize their treatment and implement maintenance versus drug holidays based on that patient and how they respond and how well they're able to maintain a remission.
It's very good. So for patients, keep track of how your skin's doing and work very closely with your clinician as you manage all of this. Okay, so let's see. We have someone that has a brown skinned person that is asking, they were diagnosed with MF stage 1 about a year ago, and they have some skin shedding. which they may have had prior to that. And is that an indicator of early, is that an indicator in early stage MF? And by skin shedding, they mean the color of a white shirt would look brownish at the end of the day, even if they're in an air-conditioned room. So I don't know if you have any thoughts on MF stage 1, maybe in darker skinned individuals, maybe how MF might show up a little bit differently. And if there's any indication on, scaling or shedding or maybe dry skin, perhaps related to that.
Yeah, so I would say that if it is truly stage 1A, this patient said stage 1, they could be 1B, then any flaking or peeling or desquamating, we call it, should be isolated to the active spots. It shouldn't be a widespread phenomenon. I don't know if Alison, if you have anything to add.
Yeah, no, I agree with that. It's very common for the skin to be flaking, regardless of the color of the skin. And but if there's kind of a generalized flaking, you think that there's probably more generalized involvement of the skin rather than more localized, just like what Dr. DeSimmone said. And so I'd be, I guess, this is a situation where I'd be asking the dermatologist I work with, do you think that this is more extensive? Should we biopsy some other areas? And probably looking into to determine whether it is a more advanced stage of disease.
Mm-hmm.
I agree.
Very good point. Okay, so this is always a good question, and I think sometimes a little controversial. So how do you supplement treatment with sunbathing? So it's always an interesting question, right? Any thoughts or comments?
Yeah, I'll take that one. So I think that kind of ties into what I was talking about in terms of utilizing ambient ultraviolet exposure as kind of free, informal phototherapy. And again, it's very much based on the patient's skin type, the degree of sun damage they already have, any history of non-MF type skin cancers or precancers, actinic keratoses, squamous cell carcinoma, basal cell carcinoma. And then once you have an individual's risk profile comprised, then you can start to determine what would be a safe amount of free phototherapy for that person. So there's no one size fits all answer, but in general, I'd say for my average patient who doesn't have any other major sun damage and who doesn't want to have to do phototherapy, or just, is maybe using steroids, but they've observed in their experience with this disease that when they get some sun, that their skin is better and they just want to utilize that. I typically say you can do 30 minutes, 3 times a week without any sunscreen in the summer. And I feel safe with that in patients who don't, again, already have a bunch of sun damage or precancerous skin change. You could do more or less based on patient-specific features and also geographic features. If someone's in Miami, that 30 minutes is a lot different than if they're in Maine.
Right. Yeah, and I think one of the other challenges is this disease does tend to like the areas where the sun does not shine. So it might be hard to expose some parts to the sun unless you have a very nice private backyard.
This is an international conference, so.
There you go.
For everybody.
That's right. Any suggestions for darkened skin pigments after electron beam therapy? That's a good question.
Yeah, that's tough because in certain skin types, you will pretty routinely see the development of post-inflammatory hyperpigmentation. So that's actually a positive treatment response. That means that you had a bunch of atypical cells that were causing sort of a reddish rash. They've now been effectively targeted by your treatment, and that transitions into what's usually a temporary post-inflammatory hyperpigmentation or focal darkening of those areas. I do not recommend any bleaching agents or retin-A or anything like that because it's highly irritating and can create some confusion as to do I have recurrence or am I just irritated because I'm using bleaching creams. Good emollients, good thick creams 2 to 3 times a day should help you. And again, usually the post-inflammatory hyperpigmentation or the darkening from therapy is short-term. That said, anything that occurs from the knees down will take 10 times longer to clear up than anything that's not on a distal leg site. So you just have to have patience with that. It has to do with how much circulation we have in the skin on the legs. That tends to be areas where you can have the most prolonged dark patches, but just try to hang in there. Don't use any bleaching creams or anything else that can be irritating, but use some good thick emollient creams like Eucerin Original or Cetaphil Original cream, and that's the best you can do.
Good suggestion. I know sometimes that the side effects can be as bad depending upon where it is, right? If it's on your face or somewhere very visible, that can be very challenging for folks. Okay, let's see. Where do we want to go from here? Let's talk a little, maybe we could talk a little bit about when is a good time to do flow cytometry. You know, that's kind of a specialized test for blood involvement in cutaneous lymphoma. And I know we talked a little bit about it's probably not needed for MF early stage 1A when we're pretty sure that the disease is just in the skin. But when would you look at doing flow cytometry for an individual, and what are you looking for that particular test to tell you about that individual's diagnosis, and then how does that maybe impact how you might treat? And I think I'll start with Dr. Moskowitz because it tends to be a more challenging disease.
So we it's possible that we check flow cytometry a little more than we should, but we do tend to check it for not for stage 1A, but for stage 1B, but where there's plaque. So there's lesions that are raised, or as I mentioned, follicular tropic disease. Because sometimes you can have stage 1B, but it's really still kind of on the verge of stage 1A, where there's just more minimal, minimally raised lesions, or just patches, and just a little bit not too involved. But if for someone who has extensive skin involvement and some more raised lesions, I will tend to check it in the blood. Or someone who has just generalized itchiness, and we maybe not necessarily where we can see the lesions, but I certainly will check it. Sometimes we find that it's not there at all. Sometimes we find a very little amount, and then sometimes we find that it's more a little bit large, a higher amount. We kind of have a cutoff where if we find 1,000 in the blood, technically we call that Sézary syndrome, and if it's less than 1,000, it doesn't quite meet criteria for Sézary. Some people are very close to the 1,000, and some people really have a minuscule amount. And how do I use that information? It really depends upon how the patient is altogether. It's not just we don't only look at the blood, but if we're looking at that, in combination with what's going on with their skin. Someone who has it in their blood and also on their skin, I still think that sometimes we can get away with starting off with treatments that just go to the skin and just monitor the blood. It doesn't mean that we have to go to systemic therapy such as bexarotene. I'm still always thinking about trying to get away with the most minimal treatment, and so that we reduce the risk for side effects from treatments. And sometimes we can get away with even just light therapy for someone who has a little bit in their blood, and and maybe extensive skin lesions, and just by monitoring the blood going forward. Sometimes for people who have if that's not working and we're thinking about systemic treatment, I still am going to try to start with a milder therapy such as bexarotene. I have found that for someone who doesn't respond well to bexarotene, even when there's a little bit in the blood, or even a larger amount, the monoclonal antibody mogamulizumab tends to really be really good at clearing the blood and getting rid of the abnormal cells in the blood. And sometimes that then translates into a nice improvement in generalized itchiness and in nice improvement in the skin. And it tends to clear the blood faster than anything else, and the skin lesions tend to lag behind. But for someone who has a little bit in their blood and I'm not getting them to feel better with, the milder treatments, usually MOGA is going to be my go-to, because sometimes that can help really improve their symptoms.
It's good to know. And I think for many of the patients out there, mogamulizumab is probably our most recently approved systemic agent for treating cutaneous lymphomas. So we're still learning a lot about how this new drug can be used beyond how it was used within the scope of the clinical trial, which was very, I won't say narrow in its focus, but it has very strict parameters. So now that we have it available to be used, we're learning more and capturing that data. And as you said, you might add it to someone that doesn't have a lot of blood involvement, but it could be a helpful agent that we didn't have access to before. So it's very good. Dr. DeSimmone, anything to add?
I have one small addition. I'm glad that Dr. Moskowitz pointed out the notion of trying to be minimal in the treatment. And I think that, again, that's contrary to how people would ordinarily approach treating a cancer. But I always try to remind patients that this is more of a chronic medical condition than an acute cancer that we should aim to try to eradicate. We, at this point, don't have medical therapies to cure this, aside from potentially stem cell transplant. So we should focus on the best possible long-term management plan of this chronic medical condition. And so I agree that monitoring a little abnormal population in the blood while trying to minimize the side effects of full bore therapy is an excellent approach. And I think sometimes we do have to just explain the reasoning behind that, because it feels very counterintuitive to how you would ordinarily want to treat any kind of cancer that you're facing.
Right. I think that's a really good point. That's a really
I
good
completely agree with that. The goal is to make sure that the treatment is not worse than than the lymphoma, than the symptoms related to lymphoma, and to improve symptoms and improve quality of life, but not cause side effects or toxicity with the treatments.
Right. And I think the other point too is around, there's still ongoing research happening. We're learning more about the disease and how it manifests and how it works, and new treatments coming through clinical trials. So, being available as these new therapies come down, or as we learn more about how to manage the disease, is also a good thought, because there's new things coming that might be helpful. So, anyway, okay, let's see. Another question related to side effects of narrowband UVB. Do you see people having skin flaking or dry skin as a result of UVB, even if it's perhaps having a positive effect on the way the disease looks or feels? But is there other side effects that might also impact the skin and how it's reacting?
Yes. So I have many patients who say, it's working and my individual patches are getting better, my plaques are thinning out, but I'm just really dry and the skin feels itchy in areas where I don't have active disease. And I think it just, it's hard to really pinpoint exactly what's going on there mechanistically, but it stands to reason that ultraviolet radiation, even in the very tightly monitored phototherapy circumstance, dries you out. And so you've got to really focus on doing the work of putting on a good thick cream multiple times a day. And I also encourage people, if they are itchy and really feeling kind of stinging outside of getting burned from a prolonged session in the light box, to try to use low potency topical steroid the day of their light treatment. That helps to mitigate the symptoms considerably. But you want to really focus on thick emollient creams 2 to 3 times a day. And then if you're still having a lot of tightness, itching, discomfort on the day of your phototherapy session, put something like triamcinolone on broadly after you get your light box treatment, and that should help.
Good advice. Very good advice. So let's talk a little bit about itch, our favorite topic that we don't have always great answers to. Any food for thought on addressing that really difficult, challenging underlying itch that sometimes doesn't all go away, or it takes time for a therapy to work for the itch to subside? Anything that folks can do while they're kind of waiting to manage the itch while a treatment is hopefully working, or so they can get some sleep at night, maybe?
So I don't know if you have any tricks, Jennifer, but you know, that it is one of the most challenging things, and you know, it's just heartbreaking sometimes to see how you know, that's one of the main side of, you know, symptoms that people suffer from. And it's absolutely true that even when we sometimes get the lymphoma under control, sometimes the itch lingers longer than actually than you know, even if the skin is improved. I mean, sometimes we do get lucky, and you know, and the itch goes away, you know, as we get the disease under control, and it's just such a, you know, it's just so that, you know, I think what makes this, you know, rewarding to take care of people, to see them, you know, just have such an improvement and be able to sleep at night. And but for people where the itch, you know, often we're kind of addressing the itch almost separately from the lymphoma, because we know that the itch can sometimes linger, and so you know, we are often prescribing medications to try to help. And I don't feel like I mean, we often start off with the typical allergy medicines, which don't seem to really work that well, like Benadryl or Atarax, but you know, those often are the ones we start with. And then if that's not working, you know, often a go-to is gabapentin, which can make you a little sleepy, and so we often try that at night, and we'll kind of increase the dose, you know, as tolerated, and increase, you know, even, you know, prescribe it during the day, and you know, and kind of titrate up and see if that can help with the itch. If that doesn't help, there's other medicines that you know, that can be tried. There's even, you know, antidepressant medicines that sometimes help with itch. There's nausea medicine that helps with itch, you know, surprisingly, apretinent, which is, you know, sometimes hard to get, but, you know, that's kind of, you know, our treatments that we'll try. But it's, you know, they're completely different treatments than our treatments that are related to the lymphoma. We're kind of trying to attack both at the same time.
Dr. DeSimmone, any additions or thoughts?
Our practices are very similar, with the starting out with hydroxyzine, escalating to gabapentin, and then titrating that dose up as tolerated. It's a horrible, horrible symptom to endure. I mean, some of these patients really are tortured, and they come in and they have scratched themselves to bleeding, and they're miserable, and they really can't sleep. The number one way, and we're talking mostly about patients who have Sézary, right? So it's having that high circulating tumor burden in your bloodstream that correlates with that deep-seated, just awful, haunting itching. So the best thing you can do is minimize the tumor burden in the bloodstream. Yes, some people still have itch even after they've reduced their measured Sézary cells on repeat flow cytometry, but most of them do feel somewhat better after they've responded to treatment. And then we just try to kind of cover up the rest of it with these types of drugs. But it's tricky because many of them are sedating. Many of them have drug-drug interactions with some of the other things that patients have to take. By and large, Sézary patients are older. They have multiple other comorbidities. They're on a bunch of other medicines that they need. So this is probably the hardest problem, I think, to fix when taking care of cutaneous lymphoma patients, because they truly are miserable, and there's no quick nor universally reliable therapy for it. So we just try and do our best to meet each patient where they are.
Yeah. One of these days we'll have a better answer targeted to cutaneous lymphomas. I hold that hope somewhere. Having experienced that intensity of itch when I was in tumor stage mycosis fungoides, I know how awful that is. Here's a good question. This is probably back over to you, Dr. DeSimmone, but how frequently can one use clobetasol? Because that's at the top end of the steroid potency. And which formulation works best? So there's ointment, cream, or foam.
So
What's your take on that?
Sure. How frequently you use it depends on how long you're going to be continuously using it for. So for example, you can, at Dana-Farber, when we have patients who are steroid naive and we're trying to treat them first off with steroids, we give them clobetasol and then triamcinolone. This is where I was taught in fellowship, and this is the protocol that we used continually, and I do that now with patients. And so what you do is you put them on the clobetasol for 2 weeks and then have them kind of downshift to the triamcinolone for 2 weeks, go back up to the clobetasol for 2 weeks for 3 straight months. And the reason that we alternate is because we want to be able to maximize all of the benefits of that high potency clobetasol, but we want to minimize the potential side effects of skin thinning, depigmentation, etc. And so that's why we implement those 2 different potencies. But what I'm getting at is that it depends how often you can use it, depends on how long you're using it for. And while there's no exact upper limit that is universal, my rough guideline is you shouldn't be using clobetasol and clobetasol alone continuously for any more than 4 weeks, and you shouldn't be doing a 4-week stretch any more than 3 times per year. There are other a myriad different ways of using it. You can use it just Monday, Wednesday, Friday, and then it's safer for many weeks at a time. You can use it Monday through Friday, take the weekends off, and that also can be done for 6-8 weeks. But you want to just make sure that you're watching your skin closely and that your provider is watching your skin very closely for any early signs of side effects related to long-term use, which again are skin thinning. You can see stria or stretch marks form. You can see pronounced little blood vessels in the skin and bleaching of the skin. If you see any of that, you need to definitely hold off on the clobetasol. And then in terms of which vehicle is better, it's largely a matter of preference. However, because the ointment, the thicker, greasier vehicle, creates an occlusive effect, that can further enhance the therapeutic response to the active ingredient. So if you use clobetasol in a sticky ointment, it's kind of driving itself into the skin. It's holding itself there because it's got that thick vehicle. Whereas if you use the cream, it gets absorbed. You don't have that same occlusive phenomenon. So you have a slightly decreased potency in the effect.
Good to know. See, these are all really wonderful. That's why I love our patient community. They ask really good questions, and these aren't the kinds of things you think to ask when you're in front of your physician, right? But it's good to know. And I always learn something new, which, after so many years of either living with the disease or listening to the science and listening to all the Q&As, there's always something new to learn. It's great. Thank you.
No, I was actually thinking that it's so nice to work side by side with dermatologists, because I learned so much from you guys regularly, and I'm learning so much just from hearing you. So I really appreciate it.
Me too.
Yeah. I think that's the beauty of, the blessing and the curse of this disease, right? You need expertise in both hematology and dermatology and pathology and radiation oncology, and it really does take a team often. So let me ask this question. So when is it appropriate to go from a skin only directed, right? We talked a little bit about, and you both shared the importance of doing the least amount of treatment necessary, right? But there's probably for some people a point where you've got to choose to add something, or the light therapies not being as effective. And so when do you look to adding maybe a therapy or changing to a systemic agent? Because we do a lot of mix and match, and I know that can get confusing for patients too, like, well, why don't they know exactly what I should be going on next? So maybe you could talk a little bit about that. I'll toss it over to Dr. Moskowitz and then back to Dr. DeSimmone.
It might be really frustrating that we don't have one path that is the way to go, but I have to say I think that I have treated every single one of my patients slightly differently because it's so individualized based upon, it's not only about their lymphoma, it's also about their life, their lifestyle and what they're able to do and what they do for a living, what other medicines are on. But so we always will try to get the most out of whatever treatment that we're giving, for as long as possible and not give up on something too soon. And, if we're trying something like light therapy and it's been a few months and the individual is really, the lesions are not improving or, the individual is uncomfortable, sometimes this can happen. If the skin lesions are kind of thicker, they don't always respond so well to the light therapy. Then we might consider adding really, often it's bexarotene to try to improve the response. And as the other side effect of bexarotene is that it makes you more sensitive to light, so you do have to be careful about that. But we in some way use it to our advantage because it can almost make the light therapy work a little better. If we start bexarotene for someone who's already getting light therapy, we basically have to make sure, I'm not the dermatologist, so I'm not the one administering light therapy, but we have to make sure they tell their dermatologist who's giving them the light therapy that they basically have to start all over again because they're going to be more sensitive to light. And so if they all of a sudden start bexarotene, they may burn, if they've been on light therapy and been, getting exposure for, at a higher level than when they started. So it is really individualized as far as when we start, but it depends upon what's happening on their skin and how uncomfortable they are, and also what systemic therapy we start really depends upon how quickly things are changing, and how uncomfortable they are or the nature of their lesions. So for someone who has maybe more lesions skin lesions where we're really worried about infection because they're breaking through the skin, so they have open sores, or where we're really seeing that the skin lesions or, maybe lymph nodes are really kind of changing in a more rapid pace. And we really need to start something that is going to work a little faster. And then I typically won't go to bexarotene in that case. And that's when I might try something like mogamulizumab, particularly for someone who has Sézary or blood involvement. If they don't have blood involvement, then often another go-to is depending upon the expression on their lymphoma cells. If they have a marker called CD30, then my preference would be to try a drug called brentuximab vedotin, which is basically targeted chemotherapy that delivers chemotherapy right to these cells that have CD30. So if you have a little bit of that can be very effective. And, in fact, it's probably one of the more effective drugs that we have for this. And then for someone who doesn't have any of those features, then sometimes my go-to is a drug called romidepsin, which I sometimes can improve the lymphoma, kind of more rapidly. And then it really depends upon how they respond. I don't necessarily continue any of these forever. It depends. It depends upon what's happening with them. Romidepsin or mogamulizumab actually can be continued on an ongoing basis. Brentuximab, the targeted chemotherapy, really you have to limit how much you can give because many people develop neuropathy or numbness and tingling on their fingers and toes. So sometimes I'll give that for a shorter period and then maybe transition to one of the milder therapies afterwards to maintain the benefit that we get from that. So it is so individualized and so dependent upon how they respond and, in certain markers. And I see I'm talking for a long time and we're getting to the end of this, but, but that's, it really is dependent upon how the individual is doing.
Yeah, it's complicated. Dr. DeSimmone, any thoughts?
Well, I think the answer to that question is a 2-hour lecture at least. So
Right.
Dr. Moskowitz did an excellent job of succinctly explaining what's going on. But I understand what you mentioned, Susan. in terms of patients being frustrated because there is not a clear-cut algorithm for us to refer to. And that, again, is in direct contrast to how many other malignancies are managed, where there are specific guidelines, and it's very reassuring and comforting to know that if this, we do that, and you're going to get the same opinion no matter who you talk to. All bets are off when it comes to cutaneous T-cell lymphoma. You could see 4 consults and you could get 4 different opinions, and all 4 of them would be right. So it's very challenging, and it doesn't lend that ease and reassurance that you get from a more concrete treatment algorithm. And that is another hard element of this disease for patients to have to navigate through. But I think having a doctor who has some experience and one who's good at communicating with you about why they would suggest one thing over another, help explain what your unique disease features are that make one therapy slightly more likely to be a good choice for you. Those things can help a lot with that element of just confusion around why your treatment plan is crafted the way it is.
Yeah, thank you. That's a really, really good point, and another good point to have that dialogue and that relationship with your physician, because this is a long-term chronic disease that could change over time. For some people, maybe it won't, but for some people it might. And to have that kind of communication and feel comfortable having those discussions and open dialogue, so that as a patient, you can make the best decision for you, given all of your circumstances and what you're dealing with. So, well, my goodness, here we are at the end of the hour already. We could probably go on for at least another hour, but thank you both for taking the time on your Saturday afternoon and answering our questions so eloquently and wisely. We really appreciate your wisdom and sharing your thoughts and perceptions and perspectives. And thanks to everybody who asked such great questions. And I think they're valuable for anyone trying to navigate through their diagnosis of cutaneous lymphoma, whether it's an early stage, newly diagnosed, or you've been dealing with it for a long time and trying to grapple with some of the challenges. So thank you all so much. And I think we're off to our peer-to-peer networking session next, where we'll have a chance to just chat amongst ourselves. And hope you both have a lovely rest of your day and weekend. And hopefully we'll see you again soon on one of our programs down the road.
Hopefully in person.
Thank you so much.
Yes,
in person.
Thank you.
Yeah.
Thank you so much. Take care.
Thank you. Take care.